Good morning. If it pleases the committee, I'll begin. My name is Joseph Conte. I'm the Executive Director of the Staten Island PPS. I'm here with a number of my colleagues to answer questions and help deliver the message about the Staten Island PPS's process and the progress to date. So the PPS is formed from a very robust and uniquely qualified group of providers in our community to transform the healthcare delivery system on Staten Island. Most of all of these participants were with us throughout the planning process. And I think it allowed us at the beginning of the project to really hit the ground running and make a lot of progress and really engage with them in a very meaningful way so that they did not feel that they were brought in after decisions were made, after funds flows were discussed, after information technology discussions were had, and it allowed us to really to develop a real flow of how we wanted to work and strategically deliver on a lot of good projects. And I want to talk a little bit about some of our strategic direction and some of our accomplishments. We completed 100% of our contractual sign-offs already, and we've distributed over $10 million to our partners. And again, much of that is related to the fact that we were prepared with a very robust funds flow model because those participants had honestly been with us from day one right throughout the planning process, and it really made a tremendous difference and allowed us, as I said, to deliver on the project implementation in a very rapid and speedy process. And likewise, that facilitated a lot of the work in our workforce planning. This past week, we had 6 PPSs participate with us in a workforce symposium. I think it really was of great value. We had the great benefit of having Peggy join us at that meeting, as well as KPMG and a number of other organizations like Greater New York Hospital Association, and we have really taken a lead in the focus on cultural competency and health literacy, especially in the downstate region. Our director of that division is working with a number of organizations to create a very robust training and communication delivery throughout the downstate region. And I think, again, this is something that has been very important. We've also spent a great deal of time focusing on the fact that we want to transition from volume to value. So we've engaged with a number of practices in the community that were not originally part of the PPS, but were able to join us afterwards during the open roster period, and they likewise really wholeheartedly embraced the idea that population health improvement is exactly where we want to be and exactly what we want to do. And we've also focused a bit upon technology and innovation, and we have implemented a telemedicine project in our nursing homes to look at how we can leverage great clinical acumen of our providers to the benefit of the patients, their families, and also looking at resource consumption and utilization. And as I mentioned, these are illustration of our progress in the projects. And in 10 out of the 11 projects, we're somewhere between 300% and 400% overprescribed on the actively engaged targets. And again, I think because of the function of working with people so early on. And the Health Home at Risk project is one I'll spend a little bit of time later on talking about. We didn't reach our target there because of the complexity of engaging with the health home, but really the importance of creating the kind of foundation that we want to have in place so that this very important project can be delivered on time and on target, and we know before the end of DSRIP year 1 is complete, we will be more than overprescribed in that area as well. This is a little focus on our governance structure. It is in front of you. I can ask questions about it later. What I would like to focus mostly upon in this area is that the governance committees are all chaired or co-chaired by community-based partners. They have a voice, they have an active voice, they're active participants, and it really drives everything that we do. This is the Project Advisory Committee, and it is an active Project Advisory Committee that spends a great deal of time during our meetings being part of everything in terms of our planning. And importantly, many of these individuals are also part of our Executive Steering Committee, so they really are driving project and projects. And if you look at the Community-Based Alliances section, all of these community-based providers have contracts with the PPS to deliver services, either in patient activation, training, or the like. So this really, again, I think creates a robust network and a platform where we can deliver the goods that the community wants because the community has a voice. This is the expenditures. We can answer questions later, but again, I think we are leading the way in many respects in terms of moving funds out into the community. And again, when you work with a partner for a year and a half, as they say, on the come, when the money is distributed, you need to distribute it to them too. And it really has made a big impact on them being able to hire up, staff up, engage staff so that they can really do the work that needs to be accomplished. And this is a little graphic about the kind of providers that we have engaged with at this point. I want to focus on community-based organization strategy, engagement and collaboration. As I mentioned, you saw highlighted the number of the partners that we have already contracted with. And again, the focus is to integrate them with what they do best, not try to create a platform for them that they are not aligned to deliver the services for. So organizations like the LGBT group that can provide training in that domain for organizations that require it, and it'll go throughout the whole network, that's what they are doing. For the organizations that can provide education about working with disabled populations, likewise they will do the same. And the patient activation group is comprised of a number of community-based organizations. Again, these are not Medicaid providers. These are community-based organizations insinuated within the community, in the neighborhoods where the individuals who need the services are. And they are working in projects like peer navigation, providing diabetes education, and doing a Project 11 patient activation program. And we really do have a very broad focus on the social determinants of health. We have 130,000 Medicaid or dual eligible patients on Staten Island and 50,000 uninsured patients. So of the 480,000 patients on Staten Island, nearly 40% are touched by DSRIP in some way, shape, or form. This is an opportunity, but it's also a challenge. So we really do need every individual to engage at the highest level of their capabilities and competencies. And as we talk about cultural competency, again, to create a sustainable and durable project, we really recognize that cultural competency and health literacy are a foundation. They're a core competency that needs to be spread to all the organizations that we work with, and we have done a great deal of work in that regard. As I mentioned, I believe we're a statewide leader. We're working on a symposium for the spring for all of the downstate region, which will be paralleled by the upstate group that we are working very closely with. And again, I think this creates a working relationship with people that makes them feel that their voices are heard, that their input is valuable, and they're bringing great benefit to us creating a transformational landscape. And again, a transformational landscape cannot be delivered without a workforce that is competent, well-trained, and capable of taking the next steps in care transformation. We were one of the first PPSs throughout the state to complete our workforce survey process, and a lot of that was done in face-to-face meetings. We are not a PPS that people come to work in the morning, sit at a desk for 8 or 9, or if I had my preference, 12 hours, but really go out, and they are in the field. They work with individuals in the community. They're out, and every community-based organization has been visited 2 to 3 times, and sometimes more. So I think it's a sign of respect, it's a sign of development of knowledge, and also enables us to create the kind of working relationship so that they are very comfortable sharing information, which in some respects could be considered competitive with individuals in their own communities. You can see we had 10 nursing homes. We have a number of community-based providers, substance abuse providers. You know, sharing confidential information like that cannot be done willingly unless people feel good about the network and the relationships that you're creating. I'm going to switch gears a little bit and talk about the population health improvement challenge that we have and how we're developing a model of care to engage the community and really focus on this. And we know we have a lot of work to do in this regard, but we recognized early on that we did not have a great focus on pediatrics at all, and we recently engaged 10 pediatric practices to focus on things like obesity and asthma and a number of adult primary practices, again, that we'll be bringing along to PCMH status to focus on things like diabetes, cancer screening, asthma, and obesity as well. And, you know, again, the idea of being here that you need to utilize the linkages in the community, not replicate them or feeling that they're competing. So if you look at that top graphic, you can see we have the Island Voice, which is a community-based organization working with the Liberian West African community, engaged with the Community Health Action Network of Staten Island and an FQHC to create a seamless kind of linkage so care can be delivered in that community. And really, you know, I say this all the time, and you know, I'm sure one day somebody will try to prove me wrong, but most of this is about developing trust. You know, access is not a function of bricks and mortar. When you have trust and people feel that they can come forward and communicate in an effective way and that they are going to get culturally competent, health literate care in a way that will make them feel that they can, if you will, let down their guard if they are undocumented, if they're recently immigrated, or whatever their concerns are, this makes a big difference, and this is really something that is a model for all the service delivery that we're working on. And I really want to spend a couple of minutes quickly on health analytics because it's the thing that gets me excited the most, and it allows us to really be very focused on the work that we're doing and really make it targeted and not a shotgun approach, but much more focused on the very specific things that need to be accomplished. And we are working with data from direct data feeds from our hospitals, from our clinical partners, from the health home organizations, and we are working, receiving all this data using data visualization tools to create heat maps and hot spotting that you can see here. It's not particularly clear on the big screen, but I hope in the packages you have in front of you you'll be able to follow along, that focuses on the cultural backgrounds of the individuals that we're trying to reach in a particular neighborhood. So targeted education can be accomplished by understanding if individuals have a background in a particular culture, so they can be appropriate, it can be identified with the way they learn, the way they understand, and it really, again, allows us to bring in a lot of variables from a lot of different platforms. So this is information that came in from the Fitnessgram. Dr. Mantello, who's up here with us from the Borough President's Office, is very focused on improving obesity on Staten Island and the pediatric population. We're able to bring in obesity data from the New York City Fitnessgram and track it with the 3 different locations of the borough, that the way it's divided, look at age, sex, and by the grade of the students, and the kind of obesity issues that are in those particular areas. And one of the big problems that we do have on Staten Island is a focus on opioid abuse. We do have an epidemic on Staten Island in this regard, and you can see, again, we can track by age, sex, by the cultural background, and the neighborhoods specifically where these issues are, and we can really be very focused about our work. So there's no point in trying to develop an initiative up here when your demographic tells you you need to focus in a particular location. So this is extremely important for us and allows us to really do a good job in delivering the goods and identifying partners in those areas that we need to work with. And all of those partners really are being moved into the patient-centered medical home model. We're working very aggressively to do assessments with them and bring them along so that they can have good focus on their outcomes and be very mindful of the fact that being a partner in a population health improvement allows all ships to rise with the tide. Another idea that we are very focused on is really focusing on this whole idea of strengthening the mental health and substance abuse infrastructure is extremely important given the kind of demographic that we just showed a couple of moments ago in this particular slide. We know we have a problem, we know we have to work on it, and it is something that we took the infrastructure project to help manage, and we have one of our partners up here from the Bridge Back to Life who's working with us on the withdrawal management service issue you, we have 7 providers working on withdrawal service management throughout the borough, and we're working on a 24/7 access to the service. You know, people don't have need 9 to 5 or 7 to 5 or 8 to 3. So we're trying to work on a call center where we can really get people help when they need it, get them at their most vulnerable time, and really let them know that we can deliver the goods.
Joe, you have a minute left.
Perfect. That's all I need. The long-term care and continuing projects is something we spent a great deal of time on. We're working with all of the nursing homes on Staten Island. Some are private, some are not-for-profit. We're working with them on palliative care, with the Interact project, and we're also working with them, as I mentioned, using the telemedicine highlight. Talking about the developing competencies and training, and this is my last slide, all of this cannot be accomplished without a workforce that is prepared, is ready to deliver on the transformational needs, and we have done a terrific job working with the training and education fund from 1199 right from the outset. They were right at the table with us throughout the whole planning process, and we have developed a great training instrument that we're rolling out throughout all of our partners in the community, and we really focus on the community-based partners, and we have a DSRIP 101 training module that is going to be implemented in the next couple of weeks.
Joe, your time is up.
And that's the last slide. Thank you.
Okay, thank you. Thank you so much. The first question is coming from Sherry.
Oh, sure.
Oh, sorry. Did anybody not hear me? Oh.
It's on, also you have the...
Oh, we just want your packets.
You got it.
That's how impressed we were.
Thank you very much. I appreciate that.
Okay, and then Arlene.
Thank you so much. I almost got up and applaud.
Please.
Great. Actually, I'm really serious. It's been probably the only PPS that I've heard that has really concentrated on the behavioral health and included addiction services in a very important way. So it's really more of a comment. Thank you so much. I'm very familiar with the needs in Staten Island, and I'm extremely impressed with the work you're doing. Thank you.
Thank you.
The next is Bill.
Thank you, and thanks. That was, I also want to applaud your presentation and on the workforce. I mean, that was such a beautiful example of what can be done working collaboratively. I mean, I guess you hosted a regional PPS meeting, so you're taking the lead, helping the other PPSs think about these issues. So your workforce component was tremendous. And I just noticed on the left side, if you could say, tell me a little bit more about your community health worker program with the College of Staten Island, because I hope that's credited, maybe. So that's what because I'm always interested in getting credits for some of the work. But can you have a word or two about that?
Sure. Not to take all the spotlight up here, maybe my Senior Director for Workforce, Bill Meyer, could comment on that. But yeah, we are working with them and other organizations around CHW work.
The issue with CHW, we're the only borough that does not have a program for CHW training. So with the TEF, we approached the College of Staten Island and said, we want our people to be able to go and get trained in the community. So we're working with them now on the development, and we do want to have a accredited program. We're in the early stages of conversation, but this, again, is part of talking with our partners. Our training process was finding out what we have and what exists. Then after we catalog what exists, what we need to get done, how do we assign that by project, and that's where we are at this point, is the current inventory, the gap analysis, and what we build going forward.
Thank you.
Thank you, Bill.
Okay, and next is Kate, and then Laura.
Sorry. Hi, thanks. I too thought it was a great presentation, and both the visuals, and that's why we were all so eager to have it. And I just wanted to call out a few things that I was really excited to hear. I agree with the commissioner, some very specific stuff about opioid hotspotting. I also appreciated that you talked about building the mental health and substance use infrastructure. So not only, kind of what programs are going on, but that we need an infrastructure, which was exciting to hear. I thought that your slide number 4, which was achievement of milestones, really looking at the metrics, was a great and really clear slide for us to sort of understand how you're looking at achieving your metrics, as well as your data visualization, kind of how do you find hotspots. That was very helpful for me to kind of see it. And I appreciated that you explicitly called out that you have CBOs with which you have a contract, and you identified those very clearly, also for us on one of your slides. And then music to my ears to hear you talking about the importance of the social determinants of health. Like much of your presentation, it's very forward thinking. It's thinking about kind of where the state and where Medicaid and the health system is trying to go going forward. So it was great to hear you kind of thinking about that and talking about that explicitly. Thank you.
Thank you.
Okay, Laura?
Thank you. I'm not going to take too much time because Kate just said many of the things that I was going to say too. I think this presentation was excellent, and you touched on things that are really, I think, could be models for how a lot of this could be done in other regions. In particular, as Kate said, the focus on social determinants of health and not just recognizing people's needs, but actually contracting with groups like Meals on Wheels and some of the other food security organizations. That's, I think, a key example for where we need to go. And also the focus on cultural competency. When you said access is not about bricks and mortar, it sounds like you know how to do this and you know how to work with the right partners to reach people where they are. And so I wanted to, just applaud you for that and hope that perhaps some of what you're doing could be used as a model.
Thank you very much. We have a great team, and again, the team is not just a PPS or a project management office team. It's the people that have come to the table right from the day one with the planning process. That's what makes it work.
Okay, Sylvia, and then Jason.
Thank you. I also thank you for the very clear presentation. I also like the slide here with the targets, and I'm hoping that you'll come up with some measures for the Domain 4 projects which don't have any targets on them. I know it's a little bit further out, but do you know how you're going to measure progress in those?
We do. We've been focusing on, there's a couple of slides in, the Population Health Improvement Project. So we will be getting direct information on a quarterly basis from the physician practices that we're working with around the particular projects that they happen to be engaged on. So that will be start number 1, and then we'll be moving into the behavioral health improvement domain as well. So I think we have some very discrete steps to begin with, and then of course, we have the underlying principles around resource consumption, preventable ER utilization, preventable hospitalization that I think are a good start, and then we'll be focusing on trying to identify from various different means, once the claims data begins to flow, a lot of focus on the kind of resource utilization around medications, compliance, and things like that, because it really is a function of good education in the offices, and if we need to work more on outreach. So we have some ideas, but there's certainly a lot to be learned.
Thank you. Jason?
Well, thank you. I don't ask a lot of questions, but I do think there's one practice that I think it would be good for you to highlight, which is your commitment to rapid cycle improvement, which I've said is one of the challenges each PPS is. What basically we're trying to do is achieve the benefits of integrated care, but do it across lots of different organizations. And one of the challenges is how does a PPS or central office collect information in a timely fashion and then support providers and constantly looking for ways to always be looking to improve and become more efficient, more effective. And I know you guys have done some really interesting things in that, so I don't know if you want to highlight your
Sure,
approach.
we could spend a couple of moments on that. For us, data is like oxygen, and if we do not have it, we cannot produce, we cannot thrive and survive. So we have worked from going from a quarterly to a monthly to a bi-weekly data reporting cycle with our partners. We're moving some people along a little more gingerly because they don't have the bandwidth internally in certain organizations to deliver that kind of data management demand. But the majority of them recognize the importance of data management being not being a project, right? This is how they do their work. So if you look at it every day and you measure it every day, then that's business intelligence. And then business intelligence can help you drive your business. So I think we're really moving people in a direction that says it's not a project. Get away from it. It's not an initiative. It's your work. And that is something that I think has really caught on. And we're also trying to provide, in a meaningful way with Dr. Volpe, the information technology team, support to people. Because it's one thing to, quote unquote, demand or request nicely. But it's another thing if they come back to you and say, well, I need help. If you can't help them, then your demand may not be reasonable. So we're really trying to work through that in a way.
Thank you very much. We have to move on to Ann.
Just quickly, I think you've heard from the panel how much we think of this PPS, and I really hate to be the skunk at the party, but I noticed that you did not get all of your money.
Right.
And so could you just touch on that briefly?
Sure. In this particular project, which is the Health Home at Risk, we did not create or try to replicate or duplicate or compete with the health home on Staten Island. We contracted with them. And because they have 7 partner agencies, the contracting process was somewhat drawn out. The criteria for inclusion into the program had to go through a process so that everybody was comfortable with engaging patients. So we would have liked to have had 400 clients. We had somewhere around 211. But once the contracting was completed, which was done in early December, the numbers have really started to pick up. So from a speed and scale standpoint, by the end of the next quarter, we will be well over the 500 target.
Thank you.
John?
My pleasure.
Yes, just a couple of things. I think the committee should be aware that this PPS has also been, at least from where I sit, the leader on one of the important functions of one of the subcommittees in workforce, and that is in the compensation survey. So congratulations on that as well. You've really helped lead, I think, everybody in that regard. And then I also wanted to just identify that I think this was the only presentation we heard where it was actually called out that in your cultural competence work you're aligning with the class federal standards.
That's
and
correct.
I'm curious about who you're working with to actually advance that compliance, which is much more than compliance, but obviously very necessary. So how are you getting that done?
So we have a director that is focused solely on this project. It's an individual who has 15 years of experience in this regard, and she has been working directly with Health and Human Services and the individuals that create those standards at the federal and speaking also at the state level and with the partner PPSs throughout the state. So it really is a collaborative effort.
Judy?
Congratulations. You answered all my questions with your presentation. I just have one more.
Sure.
What is the diversity in your governance structure?
Mm-hmm.
How do you deal with that? I mean, you have some extraordinary immigrant organizations that
Yes.
you're working with. I mean, Make the Road and El Centro.
And they're outstanding.
Yeah, exactly. So how do they get incorporated in the decision-making process?
So they're involved in the committee structures that they're most comfortable with in terms of their participation, and they're also on the steering committee. So the steering committee really is our driving focus from the governance standpoint.
And the steering committee makes decisions?
Yes.
For the PPS,
Correct.
including allocation of dollars?
The finance committee, of course, is the foundation of funds flow, but the steering committee has an approval vote. That's correct.
Judy finished. Okay.
Anyone else?
That was it.
Thank you very much.
Thank you.
Oh, wait. We got time. Cho has a question.
So this is actually less of a question. I actually thought this was a great presentation and also a model for many of the other PPS. There's another opportunity that's just recently come out about accountable health communities. And I wonder, what is our role, or what is your role, in a sense, Jason, in terms of thinking about how do you support potential PPS models that could be the integrators that support entire communities, such as Staten Island or other places?
Sure. So that's a federal grant, in essence, grant program, and actually it's the providers who are the applicants. However, they need a letter of agreement from the state Medicaid agencies that the state Medicaid agency will commit to it. And so what I think we're open to is any organizations that think that they can qualify to approach us, and we're more than happy to be supportive of application efforts. And I do think, though, that the PPSs are uniquely positioned, given their mission and what they're trying to do, to work exactly in that direction and use that infrastructure, which I think is unique, because a lot of them are community-wide. They have a lot of the stakeholders at the table. So I think it could be very much a natural extension of what PPSs are doing today.
Okay, Sylvia's our last because...
Yeah, I just wanted to say on that item, we've been hearing from some of our local health departments who are interested in partnering with some of the other systems out there. So if there's any way that we can be helpful and connect the dots on this, I think it's a great opportunity. It'll help achieve some of our prevention agenda goals as well.
So Sylvia, would you be the contact person for PPSs that are interested in pursuing this?
I think it's got to go through Medicaid.
Oh,
but I think
right.
we've
So
talked,
through
Peggy and I
then-
have talked
yeah.
about how to
Okay.
connect on this.
Well, thank you very much.
Thank you.
Thank you very much.
If I could again ask if my colleagues could introduce themselves.
Please. Into the mic.
Jeannie?
Good morning. I'm Dr. Ginny Mantello. I'm the Director of Health and Wellness at the Borough President's Office, and I work very closely with the PPH on the population health improvement projects.
Morning. I'm Dr. Sal Volpe, and I'm the Chief Medical Officer.
Good morning. Bill Meyer, Senior Director of Workforce and HR.
Good morning. Richard Olson. I'm the Chief Financial Officer.
Good morning. Kristen Diraspina, Senior Director for DSRIP for Staten Island University Hospital.
Everett Miller, Bridge Back to Life, working on the withdrawal management and the co-location of primary care into behavioral health project.
Thank you again. We're going to break for lunch now. We have 45 minutes for lunch, and we will start with Nassau Queens at 12:30. Right? Not an hour today, 45 minutes. Okay.